Welcome to Mercy Medical Center's live webinar. Today we will be discussing breast cancer treatment options. Joining us is Dr. Jasmine Nabi with Oncology Associates at the Hall-Perrine Cancer Center. After a discussion, she will take questions from our audience. To submit your questions anytime during the discussion, go to the window in the upper right-hand corner of your screen and type in your question. If you don't see the screen, click on the orange box with the white arrow. Your questions will be confidential. Well, welcome to the webinar, Dr. Nabi. I'm going to turn the mic over to you now so we can get started.
Good afternoon. Thank you for joining me today. And so obviously we're going to be talking about breast cancer, and so I just wanted to give some basics before we get into a more detailed discussion. So I think it's always helpful to understand the anatomy of the breast and the purpose of the situation. So when we talk about breasts, we have these lobules. That's where breast milk is produced, and then these lobules are connected to ducts. That's how breast milk gets to the lobules to the nipple. And so because of the anatomy of the situation, there are different diseases that originate from these different sites. And so the four most common types of breast disease, we have the lobular carcinoma in situ. That means that the disease started in the lobule and stayed within the lobule. So it did not invade into the breast tissue. The invasive lobular carcinoma means that the disease started in the lobule and did go into the breast tissue. So that would we say is invasive, and that would be considered something that would need more intensive therapy. And then when we talk about the ductal carcinoma in situ, that means that the disease started in the duct and stayed within the duct. And then the invasive ductal carcinoma means that the disease started in the duct and invaded into the breast tissue. So when we look at the different categories of disease, we consider invasive more of a concerning situation. So moving on to another form of breast cancer. Is inflammatory breast cancer. So as you can see by this appearance, that the breast is red, and so essentially what is happening in this situation is that the disease is invading the cells of cancer are invading the skin, and so it gives it a red, warm appearance, and for some patients it can have the texture of an orange peel. So after we have some of the basics, we can define the disease, and that helps determine the treatment. So I'm going to go through these things one by one. So very important in determining the treatment of the disease is the stage. And so the stage defines how much disease is in the body. So it's very important to know the size, and then whether or not lymph nodes are involved. So lymph nodes are the draining system of the body. And so the disease can not only invade the breast tissue, but it can go into the lymph nodes. And then we also ask about metastasis. That means, did the disease not only go from the breast tissue to the lymph nodes, but did it figure out how to get to other areas of the body? So breast cancer has the capacity to go to the brain, the bones, the lung, and the liver. So again, that would be considered a metastatic situation. The disease has gone outside of the breast, outside of the regional lymph nodes, and to distant areas of the body. Also important for defining the disease is estrogen and progesterone receptors. And so in that situation, the disease is stimulated by hormones if the disease is estrogen and progesterone receptor positive. So again, the disease is fueled or driven by hormones in that situation. And that's an important thing to define, because we have drugs that block the effect of estrogen and progesterone or block hormone production. Another important category when we're talking about breast cancer is the HER2/neu status. HER2/neu is a growth promoting protein. And so we have drugs that prevent the stimulating effects of the protein on breast cancer cells. And then some alternative things that are optional for when a patient is diagnosed with breast cancer is Oncotype DX. So this is newer technology where the genes of the tumor itself is tested. And we use this to help define risk. And so we're usually deciding whether or not someone needs more traditional chemotherapy or anti-hormone treatment for a patient that has lymph node negative or estrogen positive disease. So again, we're trying to help define the treatment when we're trying to determine their risk of recurrent disease. And so we're looking at the actual tumor gene. So it's a very exciting area where we're trying to define treatment based on the tumor itself, not just overall appearance for the patient. And then also we have the BRCA mutations. So this is where a patient could have a genetic mutation that can increase their risk of breast cancer. It should be noted that only about 5% of all breast cancers are associated with an inherited mutation. Red flags that would help us understand if a genetic mutation is in the family is if a woman is diagnosed with breast cancer at an early age. We consider that someone diagnosed in their 30s or 40s. Multiple family members diagnosed with breast or ovarian cancer is another red flag. And it's typically under multi-generations. Some ethnic groups have a genetic predisposition, such as Ashkenazi Jewish population. And then some women or some patients have multiple breast cancer diagnoses. So they were diagnosed with breast cancer in maybe 2007, and then 2004 another breast cancer showed up. So that can be a red flag that a particular patient is having multiple breast cancer diagnoses. And then also another concerning factor is if male breast cancer is diagnosed in the family. That could be a sign that there is a genetic mutation. So when we've defined the disease, then we can talk about treatment options. And there are various treatment options, and I'm going to go through them individually. So obviously, just to kind of broad stroke it, there are three main weapons that we have against cancer. We have surgery. That's where the surgeon cuts out the disease. We have radiation, where we use beams of energy to treat cancer. And then we have medicines, basically medicines that are designed to treat cancer, and that could be the traditional chemotherapy and hormone therapy. And I use hormone therapy and anti-hormone therapy interchangeably. Basically, we're manipulating the situation when the disease is estrogen and progesterone receptor positive. So if we focus on surgery first, there are different types of surgeries. So when we talk about the first one, lumpectomy, that's basically saying a breast conserving surgery. So we're removing just part of the breast. In that situation, if we remove part of the breast, then we have remaining breast tissue left behind. And we typically talk about a patient needing radiation after a lumpectomy. But again, that may depend on the overall situation. Mastectomy refers to when the entire breast is removed. And in that situation, a patient may or may not need radiation. It just, again, depends on the situation. So after we've talked about the lumpectomy, removing just part of the breast, or a mastectomy, removing the entire breast, we also need to talk about the lymph node situation. And so we sample the lymph node with this technique called the sentinel lymph node biopsy. That's where we examine the first few lymph nodes in which a tumor could drain into. And so what a surgeon does is they inject a radioactive substance or a blue dye, and that leads to the sentinel lymph node. So it's basically a roadmap or a trail leading to the lymph nodes that would be at most risk for having cancer cells travel to it. An axillary lymph node dissection is where all the lymph nodes in the region are removed. So moving on to the next slide, this is a picture of lymphedema. And hopefully you can appreciate that this arm on the picture on the left is enlarged compared to the arm on the right picture. And so when this risk would occur is when the lymph nodes are removed with surgery or damaged by radiation. So you can see that there's a swelling of the arm, and it could also go into the breast depending on the situation. Patients who undergo an axillary lymph node dissection are at higher risk for developing lymphedema. Ways that we try to avoid lymphedema is avoid blood pressure readings from the side that had surgery, and we also typically tell patients to not get IV drawn from the side that had surgery. If a patient does develop this complication, we do have treatments. We can talk about a compression sleeve or massage therapy, and so that's kind of a way to kind of compensate for something that has affected the draining system of the arm. And I should mention that sometimes patients who go air travel can have a lymphedema situation by the change in the altitude and pressure that can sometimes provoke a swelling of the arm. Going on to radiation, again, that's beams of energy used to treat cancer. There are two main techniques of delivering radiation in breast cancer. One is external beam radiation. That's where a patient basically sits under the machine and the entire breast is exposed. And then we have the second category, which is internal radiation or brachytherapy. And a brand name of this internal radiation or brachytherapy is Mammocyte. Basically, in this situation, a balloon is inserted into the lumpectomy cavity where a surgeon did surgery, and then the balloon is inserted, and then a catheter is remaining outside of the breast. And in that situation, a radiation seed is inserted into the balloon and is exposing radiation internally. So that is newer technology. Not all patients are a candidate for the internal radiation, and again, depends on certain characteristics of the breast cancer. And then my area, as a medical oncologist, I give medicines to treat breast cancer. And so essentially, there's two main categories of medicine to treat cancer. We've got chemotherapy, and that's a broad range of drugs. And so how we determine who gets what drug really depends on how we define the disease. And what I've kind of explained before is that hormonal therapy or anti-hormone therapy, it's only effective in patients with estrogen and progesterone receptor positive disease. So in that situation, we're using medicines to stop the production or block the effects of estrogen or progesterone. A very classic drug for hormone therapy is a drug called tamoxifen, and again, that's an anti-estrogen drug. And then a newer class of drugs is called an aromatase inhibitor, and there are several aromatase inhibitor drugs on the market. And essentially, they're used for postmenopausal women to stop the production of hormones. So I know I've given a broad overview of things. I open up the site to questions.
Well, thank you, Dr. Nabi. That was great information. And to remind our listeners that questions can be submitted from the box in the upper right-hand corner of your screen. Okay, to begin with our first question, Dr. Nabi, is the photo of inflammatory breast disease that you showed in the slide, is that typical of appearance of that disease?
Yes, it is. So I don't know if we can move the slide back to that picture. So as you can see, there is a generalized redness to this breast, and then I know it can be hard to appreciate on this picture, but the skin can be thickened, and like I've mentioned before, it can look like an orange peel. And again, that comes from the disease invading into the skin. Sometimes it doesn't have to be this extensive or this cherry red color. Clearly, sometimes when a breast looks like this, sometimes there's concern for an infection. That's where if a woman develops a situation, they should absolutely contact their healthcare provider and actually have this evaluated. Yes, it could be something like an infection or an infection of the skin called cellulitis. Women who are breastfeeding can certainly have that situation, but when it's not clear, that's where your healthcare provider helps sort out the details.
We're going to move the slides forward here. Questions? Okay, next question, Dr. Nabi. How do you feel about exercise as part of treatment, both during treatment and post-treatment?
That's a very good question. So we do recognize for patients' well-being that exercise is a good thing, in addition to exercise, a good healthy diet in general. I think that when patients are undergoing treatment, depending on the treatment that they're doing, exercise is a good thing. But for example, if a patient is doing intensive chemotherapy, sometimes that person may not have the stamina or strength to keep up with an exercise program. That's why I often recommend patients, if they're interested in keeping physically fit during treatment, is that they work with what we have at Mercy is the Thrive program. So that program really goes into detail about what the patient's actually doing for their treatment plan and tailors their treatment plan to the exercise program that's recommended. Again, in general, I do think that it's good to have a good healthy diet and a good exercise routine. And when a patient is doing treatment, that can be very difficult to figure out. And I think that sometimes supervision with someone with like the Thrive program or a wellness program, it's a good idea. And also, the question's also asking about post-treatment too. I agree that there have been studies to show that patients who are healthy and are fit, that their risk of relapse is less. So I think that is a very good part of their treatment.
The physical as well as the emotional benefits of exercise is so important. Another question, can you explain why massage can help with lymphedema? You mentioned that earlier in the presentation.
So maybe we should also go back to that picture too. So again, lymphedema is where the arm can't really drain the excess fluid because the lymph nodes have been damaged or removed. And so by doing massage, we can kind of manipulate that fluid out of the arm, or a sleeve can help prevent that fluid from accumulating in the arm. So these are good techniques. And if a patient does develop this, we do have a lymphedema clinic where a physical therapist specialist kind of works on teaching a patient the massage techniques and kind of fitting them for the right kind of compression sleeve.
If a woman is post-menopause, why would she need to be on hormonal treatment? Could you explain that in a little bit more detail?
So I actually get that question quite a bit. Patients say to me, well, I'm in menopause. I don't make any hormones. Why do I need to be on any kind of medicines? And I say, well, just because your ovaries are no longer kicking out hormones, that doesn't mean you don't have hormones being produced in your body. Fat cells and adrenal glands are all capable of producing the estrogen and progesterone. So again, it's not just about what your ovaries do. It's about you in general are still making these hormones, maybe to a lesser degree, but we want to turn off the stimulation. We want to block the effects of the hormones given the history of estrogen progesterone receptor disease.
Dr. Nabi, you mentioned male breast cancer. How common is that? We just don't hear much about that.
So I would agree we don't hear much about that because it's not very common. And so I've been practicing oncology for about 5 years, and I've seen it twice. And so we still do the same treatment techniques. And so I would say that It's not very common, but it's certainly out there, and it can be a marker for a genetic predisposition for cancer in the family.
Next question. What is the most exciting new treatment coming out? Is there anything out there in the horizon that you may know about?
So right now I have clinical trial options for patients. So I think that's a very important thing to promote, is that, you know, the things that we do standard, that's the best that we have in 2012. But we always want to do better for our patients. We want to figure out the best way of not only improving survival, but we want to improve quality of life. And so clinical trials, whenever I can, I try to give as a patient option. Right now, we had a clinical trial looking at TDM1. That is where we are looking at the treatment Herceptin linked to a traditional chemotherapy. So essentially, we're combining drugs that are not just targeting the proteins, but we're actually using the protein targets and linking it up to chemotherapy. So we're really trying to get more specific and really targeting our disease with the traditional and the targeted. So I think that's a very exciting thing.
Here's a million-dollar question. How can we prevent breast cancer?
So that is a very a common question when a woman's been diagnosed with breast cancer. Why me? Why did this happen to me? And I always say, look, it's just bad luck. Unfortunately, breast cancer is just a common disease, and so I think that it's important to get the screening mammograms. It's important to maintain a healthy lifestyle with diet and exercise, but also to know that even you can do everything perfectly and something still happens. So research still needs to be done on why this is happening, and but there's just some things in medicine we just don't know.
And again, emphasizes the importance of screenings and early detection. We have a couple questions coming in here. Dr. This is a question about the effect of breastfeeding on future breast cancer. Is there any link between the two?
So for whatever reason, women who have never had children or had done childbearing later in life tend to be at increased risk for breast cancer. I'm not aware of breastfeeding in particular being a risk factor of whether or not someone develops breast cancer. But again, it's about, right now, the situation is if a woman has never had children or had childbearing later, that would be the thought that they could be at increased risk for breast cancer. But breastfeeding in general, I'm not sure.
Another question. There's a current debate on the age of when mammograms should be started for women. What are your thoughts on age? 40 years? 50?
I know that that's gotten a lot of press over the years. And so at this point, I still recommend women doing their first screening mammogram at age 40. A woman might get a screening mammogram done sooner if there are other risk factors. For example, if your mother was diagnosed with breast cancer at age 45, then we might say, look, you need to get your breast cancer or your breast mammogram done at age 35, so 10 years before the family member was diagnosed. So it's, yes, in general, a screening mammogram, I would say at age 40, but there might be some things that may make that a sooner recommendation.
The question, can you talk about the side effects of some of the medications that are used to treat cancer?
So that's also a very good question. So I think the person who submitted the question specifically asked about tamoxifen. So tamoxifen, again, is an anti-estrogen drug that we typically use in premenopausal women who have estrogen progesterone receptor positive disease. And so when I meet a woman that's going to need tamoxifen therapy, I say there's really three main side effects that you should be worried about for tamoxifen. One is an increased risk of blood clots. And so a blood clot meaning a blood clot in the leg, where we call that a deep venous thrombosis. They could also develop a blood clot in the lungs, where we call that a pulmonary embolism. Another risk of tamoxifen is it can cause hot flashes or other hormonal type symptoms such as vaginal dryness. And finally, tamoxifen can cause an increased risk of uterine cancer. So patients who are on tamoxifen, I recommend that they continue their pelvic exams with their primary care provider. When we're talking about the other category of anti-hormonal therapy is the aromatase inhibitors. The aromatase inhibitors, their three main side effects would be that it can cause body aches or joint aches and pains. The aromatase inhibitor can cause an increased risk of osteoporosis. That's why I have patients on that drug do baseline bone density scans and take calcium with vitamin D. And then finally, the aromatase inhibitors can cause an increased elevation in their cholesterol levels. So it's important to continue your relationship with your primary care provider to kind of make sure that other aspects of your health are being taken care of.
If you have additional questions or concerns about this topic after the webinar, I would encourage you to call Sally Bulow, who's the Oncology Nurse Navigator, and she can be reached at 319-398-6718. We have another question here. Is sentinel lymph node just choosing just a few lymph nodes for cancer? So maybe explain the difference between that and the complete.
So the sentinel lymph node is not meant to be a complete clean out of the axillary lymph nodes. It's meant to target the lymph nodes that would be most at risk for having cancer travel to it. So that's where we call that the sentinel lymph node being tracked down by doing the blue dye. And so you're injecting the blue dye into the tumorous area, and you follow the trail and sampling the lymph nodes that are lighting up. And so it's not meant to be a complete, it's just it's meant to really target the lymph nodes that would be at most risk of having cancer go to them. And it's great if the lymph nodes are negative, and so if a lymph node is positive, that means that we're saying, look, you have higher risk disease.
I just want to point out our next webinar topic is titled Why Choose MBI for Breast Cancer Detection, Molecular Breast Imaging, and Dr. Laura Heyman will be our presenter. This will take place on Thursday, October 25th from noon to 1, and she will also take questions live after the discussion. I believe we have covered all the questions that have been submitted to us. But again, remember, if you do have additional questions, to contact Sally Bulow on the number 319-398-6718. Thank you all for joining us today.